And it's unfortunate because that's hormones is the quintessential importance of personalization. You know, I think that functional medicine, conventional medicine, yeah, sometimes it's easy to sort of figure out some complex thing and treat it, whether it's prescriptive, nutritional, a supplement. And it's almost like this linear way of thinking, like, oh, I'm just going to do this, 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 this. And that might work for a few things, but quite honestly, hormones, no way. It's sophistication. When you think sophistication and complexity, it's not linear. It's not. And when we talk about hormones, especially now with social media, it's out there. It's like everybody asks now. And people think, oh, hormone equals health and hormone equals beauty and hormone equals I'm not going to kill my husband. And the reality is, no, it doesn't. You can give somebody hormones and they'll still do those. And actually, I have patients coming to me and say, I went to this clinic and I got my 3-pack. I got on estrogen, progesterone, testosterone all at once. And now I feel like crap. And I'm like, yeah.
Welcome to Influence to Death, your guide for navigating the wild world of wellness influencing. Hi, and welcome to Influence to Death. My name is Victoria Lafont.
I'm Hannah Wright, and we're joined by a wonderful guest today, Dr. Angie Martinez.
Hey, Dr. Angie.
Hey, gals. Thanks for having me on.
Yeah, thank you for being here.
So this episode, I'm technically kind of billing it as BHRT, bioidentical hormone replacement therapy. But that's just one little sliver. I know, Dr. Angie, of what you do. But the reason I built it that way is because we were having a conversation, Dr. Angie and I were, it's been probably a couple months ago or last month, we had a session together, and I, right up front, will say, like, I have had a bias for years, like a negative bias around hormone replacement therapy. I'm like, if women want to do it, go hard, total support, whatever. But for myself, I have this like hold back where I'm like, well, that's not how, our ancestors did it. Like, I really put that ancestral lens on top of it. And I said that to Dr. Angie, and the whole episode is you going to be clarifying this, but you said, well, yeah, they didn't. And then they like suffered from the consequences of not having those hormones interact, and in their bodies. And it was like the first time you hear a new idea or like a new concept comes into your head. And I was like, oh, I'm going to like bleed out my eyes. Like, it was so, I don't know. It just hit me in this certain way where I was like, of course, like,
wait a minute.
Yeah. So since then I've been gracefully stalking Dr. Angie to be like, hey, please come on the podcast. And then again, to say it's not, she just doesn't just do hormone replacement therapy. I was incredibly impressed just with your work, period, in medicine. So are you comfortable with us reading your bio a little bit, or would you rather just, okay, cool. Some people are like, no bio, please do not do that. So I'm actually really glad we're going to read her bio because the first line is so stellar. So she says, I am an unconventional medical doctor, which I was like, oh, yeah, that's so cool. Okay, so Dr. Angie Martinez, she is a board certified conventional family doctor and a board certified functional medical doctor. So both. And she is located in Colorado. And you have an active practice of seeing your patients. You're not just online doing talk.
I'm in the arena. Day in, day out.
Yes, you're totally in the arena. Okay, so she is a Colorado native from the San Luis Valley. And so in her bio, she says, my foundation of medical knowledge was influenced by my late grandma, Irene, who would pick wild medicinal herbs to help with our illnesses. She was my healer. I didn't have access to traditional medicine until my 20s. I received my required childhood vaccinations by visiting a school nurse. And I learned in those years that our body has an innate ability to heal without modern medicine. With this foundational knowledge, I continued my mission to be a medical healer and graduated from Colorado State University with pre-med studies and continued my loyalty to Colorado by attending the University of Colorado Medical School. I wrapped up my enduring traditional medical training at Rose Family Medicine Residency. I learned in the conventional world that there are sophisticated technologies and knowledge, along with pharmaceutical advancements, that can help support illness and disease. I would spend the next 15 years working between Denver Health and Kaiser Permanente as a conventional family doctor. This was an amazing journey with great learning experiences and growing frustrations with the challenges of the conventional medical system. Conventional medical knowledge isn't adequate in addressing our modern 21st century chronic illnesses. Its costly, sophisticated knowledge and medications do not heal or allow the body to heal itself. I started feeling uneasy and incomplete in this practice. I found myself longing to go back to my roots and my foundation. I started a new chapter in my journey with additional skills training with the Institute for Functional Medicine. Like a gardener, functional medicine respects the root health, the health of the soil, and the environmental influences that affect health. I am a gardener, and functional medicine's paradigm of looking at the root cause of symptoms, illnesses, and system imbalances of chronic illness aligned with my values. I am learning that I can now practice with sophisticated scientific knowledge about body systems, medications, medicinal herbs, and vitamins to support our body's innate ability to heal and find balance. Yeah, and I think it's good to say your practice is called root cause medicine, functional medicine consultation and wellness clinic, but there's a big story behind that. So
I love that story so much. I love the story about your grandmother.
I know.
That just, I felt that. Yeah.
Same. So, okay. I mean, do we kind of just want to go right into this piece that I was like, what? I think it was so surprising to me, Dr. Angie, because I tried to think about any impact that we're experiencing now from an evolutionary lens. Like, I've even investigated my rosacea from an evolutionary lens. Like, why would this be a beneficial thing? But I had never thought of hormone replacement therapy in that way. So take it away, please.
Absolutely. Evolutionary. It's interesting when we look through that evolutionary lens. It's important because we learn a lot from that. But we're in modern times and we're sort of out of bounds when it comes to evolution in some ways. So for example, if you think from an evolutionary lens, it wasn't until we were living till 50 up until the 1950s. And then we jumped into another decade over the next 50 years. And then up until now, our lifespan is 67, 60, 76 or 78, depending on, what papers you look at. So from an evolutionary standpoint, we didn't live long. So we can't, when you look at that, and that wasn't that long ago, that was 1900s. So the whole idea that, this grandmother theory of we gave up on hormones so we can take care of the tribe sounds great. And it probably is to some degree important and very much important from, survival, getting that wisdom. But I don't know if hormones tagged on that as much because, our longevity crunched. We haven't been living long for long. So, I think when you look in the, longevity world, because I like that, it's more biology. It's more from a biological lens that says, hey, it's interesting why a woman comes to a complete stop, regardless of her, her culture, her health, her environment. We all come to a stop about the same time. And a guy's going to take his sweet time, losing his hormones.
Of course,
and we come to a complete. He can have children up until 80 if he stayed healthy enough. And we come to a complete stop. Like, why do we do that?
Yeah, why? Why?
So the grandmothers, I don't know if we've had enough longevity to have evolved around that, but I think that there's definitely something about the science of it in terms of longevity for us. So when you think about longevity, there's a lot of things that we need. So for example, we haven't been living long for a long time. That was sort of the point. And so we're in a new era. To go from 50 to 90 is a new era for women. And even before we had that longevity, in the 1900s, somehow we were sort of already doing this, from a biological standpoint. I think from that longevity lens, we look at it from an energy standpoint. So the thought is that Mother Nature did us a favor to take that burden off of us because it costs too much, so that therefore we can use our energy to survive whatever's left. At that point, it was 20 years. Now it's 40 years now.
Mhm.
And so because it's longer, now we have to sort of think about, okay, if we want a longer health span, in lack of hormones will shorten our health span. And we haven't had enough time to evolve around that, but we're so modern these days that now we can say, oh, if we want to have a prolonged health span, can we just give the hormone back?
Yeah.
And, when we age, we become insulin resistant. We medicate that. When we age, we get high blood pressure. We medicate that. This process is just this evolutionary process of trying to support, now that we're sophisticated enough, support that health span so that we're healthy in 40 years.
Mm-hmm. Can we talk about the grandmother hypothesis really quick? Because when I looked into that, I actually never ever heard of that before. And I will say I know very little about hormone replacement therapy, really about the menopausal transition. I'm starting to learn more.
You're gonna learn, girl.
I know that's what Dr. Angie and I were just talking about.
You're gonna learn
earlier. It's like it's gonna hit me at some point, and so
I
I need to know.
I'm like, wow, I'm like warm for the first time in my life. So love a hot flash over here. Unpopular opinion.
Yeah. So what is the grandmother hypothesis? What does that mean?
So that grandmother hypothesis was trying to explain why we would stop having hormones. And the thought is that maybe overlapping a little, that we stop having hormones so that we're not in the competition of evolution, which is, breed and have, or at least not breed because we're not animals, but, have children and keep building the tribe back then. The idea was that there came a time to stop so that you were allowing the younger women, to pass along healthier genes, to keep, that healthy genetic profile passed along. And then it was a good thing because then now you weren't in the pond trying to look to continue having children. Now you can relax and train and pass down wisdom. And so that was sort of the idea, is that you got out of the competition, moved into another role of passing down really important information that allowed for the tribe to continue to survive.
Yeah. Yeah. And as I was just reading through, like I happened upon that, Hannah, I happened upon it when we were writing those ebooks for Health Means years ago. I just stumbled on it. It looks like there are a lot of different theories around why women live past, because it's like very rare, right, in animals that, like, I saw one like toothed whales have a menopause, but there's like very few other animals that live past their ability to reproduce because, and look, you stop me, Dr. Angie, if this is wrong, but biological imperative is like you need to produce survivable progeny. Like you need to have kids that survive. And then after that, evolution's like, you did it. Which
we don't need you anymore.
Is what made such good sense to me when you were like, well, there's going to be 40 years of whatever you experience after that. And evolution isn't super concerned with you then.
Right. So the grandmother hypothesis is kind of explaining why would we keep living basically as human females? Like, why do you go on when other animals you don't? You just die, or nobody cares about you anymore because you're kind of worthless, which is kind of really depressing to think about. Like when I read that, I was like, oh God, is that all I am? Is like a uterus? That's
in evolution's eyes, maybe, right?
But I think they called it grandmother because at least they defined it with some purpose, that it wasn't just that, you're done with your uterus. It was another level of purpose, which I think is a new concept that's coming back, and this empowerment of women is coming back and saying, what is that for women? Because we've been, overlooked in medicine and just and neglected. It truly is neglect. And unfortunately, at least, this generation, 50, 60-year-olds, are probably, I mean, to some degree have been affected in longevity just because of the women's health initiatives. So I think that, just having a sense of that purpose is important to bring into that grandmother theory, that it wasn't just like, oh, I'm done. It's like, no, there's another level of importance.
Right.
And wisdom is. And I think, in this new movement, that's sort of what a lot of of women are bringing back, that, oh no, there is an important part of what we need to find. Because I think women identify themselves with that part of their life too. And so they get through their menopause and like, what's my purpose now? And so, so there are a lot of growing, I guess, focus on what that's going to mean for a woman, because it wasn't defined. It was just, nobody talked about menopause. So therefore then it was, how do you move on? How do you explain things, that you feel, which is like crazy. Yeah. So at least, so it's overlapping a little to where we are now, but at least with that purpose part.
Yeah.
Purpose is so essential. I mean, just for anyone's longevity and health outcomes, like having that feeling like you have a purpose, you're contributing to your community, your society, no matter the age. Like you can see that studied, and so that's interesting. And you see it in women. And I realized when I was reading about that, like that's why I think personally I've always been so turned off or uncertain about menopause and learning more about it, is because I'm kind of scared of it. And I think it does come down to, even though I'm a mother, but I also work and I obviously have all these other projects and purposes in my life now and interests and things. I still feel like, I guess it's just ingrained in me, like, because I'm a woman, that's my purpose is to, carry a child and take care of a child, even though no one ever told me that as a child. I wasn't like, my mother wasn't like, you're going to have babies and this is what you do. And, that's your job. But I'm realizing it's really just in me. And it kind of is a deep seated thing. And when you lose that ability to no longer, be able to be fertile, it's kind of, you're like, oh, well, that's weird. Like, what am I going to do? Like, how, I don't know. It's just it's an interesting like lens to look at it through, is that emotion we have tied to our fertility as women.
Yeah, because I think the narrative is that's our identity. And I think
Right.
that's what the movement is about now. It's like, no, it's more, because you're going to have another 40 years and you
Yeah.
have to
And that's
figure out what,
exciting.
Meanwhile, I'm
yeah.
like, I can't wait for that because I'm just going to have so much unprotected sex. Like, just crazy, wild. Like,
And
I
women
love that.
do. Yeah. It's interesting to think of like the experience of watching women going through that, and seeing them. And it's an identity crisis because, oftentimes by 50, their children are off, they're empty nesters. Um, and they go through a identity crisis, and that's actually the time where there's the most divorces, because then they take on a new identity and move on. And so like you'd mentioned, Hannah, it's like you have, and that might be the evolutionary part, is that I know I got to be a mom. Here are the things I do. I'm like making sure I raise a child and get them healthy and out. And then there's this transition, and our modern world hasn't really defined that. And I think that's where this movement's going, is that defining that and being proactive. Victoria, as we mentioned, that, yeah, you got another 40 years. And if you don't have hormones, because somebody, women who are, 60, because the Women's Health Initiative doctors are not giving them out. They're still not quite, that's less than 10%. Conventional docs will prescribe a hormone. And,
Wow.
yeah. And if you
Why
don't
is it
have,
so low?
because in 2002, the Women's Health Initiative came out and said that if you give women hormones, she has a higher risk of cardiovascular disease and breast cancer. And that was right smack when I was doing residency. So I was trained to think that estrogen meant, in a woman in who's older is, going to be cancer. And so you're trained with that fear. So my generation of doctors just have that fear of the World Health, the Women's Health Initiative. And unless you're really wanting to be an outlier, which most doctors aren't, and you're, worried and going against FDA and going against all these things, you don't know about hormones right now, unless you're going back and getting retrained. And by my generation right now, they're just burnt out sometimes, oftentimes, and they're not going to go back and get trained on that. So maybe the younger crowd, I think, is interested. I know that they're prescribing. I see people coming to me, but it's not trained, so they're not prescribing correctly. And so, yeah, we'll have a lot of transitioning to do around that.
Yeah, it's so interesting. Like, living in Boston, it's like some of the best medical in the country. And I went to just see my NP last year, and I was like, "Hey, I almost killed my husband because he ate the last banana the other day. So, like, could you talk to me about that?" She was like, absolutely, like, they're fabulous. She was like, we actually have this woman in the office that we call the perimenopause whisperer. And she like pulled up this chart, and she's like, okay, this is you when you're cycling, and thankfully, I know a lot of women don't have like the nice, cycles of hormones. Like they really struggle with that. But I was very lucky in that way. And she's like, but that's kind of how it should look. And then here's like after menopause, and it's just like this straight line, and she's like, you're right here in the middle. And it looked like a 4-year-old had taken a crayon and just like completely gone wild. And she's like, yeah, you're gonna feel crazy, and like we can test your hormones. And then she was like, look, we could prescribe like birth control or just like a singular progesterone. She like gave me options, which I'm dumb as a brick about hormones. But there was that willingness to have the conversation and to prescribe. But I also know, like you're saying, I'm like in the city center of Boston, and I'm about to move to Kentucky. It'll be very interesting to see like what the difference maybe is in options and prescribing, and what the education level is. Not that Kentucky is like behind or something, but that it's more rural. It's not as many teaching hospitals and like that. And I have exactly what you described, where I've been afraid of hormones because of that lingering, I guess it's like
uncertainty.
there's not an update of that information of like, is it going to give me cancer? Is it going to cause cardiovascular disease? Or, like all these different fears.
And that actually has been updated. The Women's Health Initiative has been debunked in terms of that just recently. So that's sort of why that movement's going. I think a lot of leaders in women's health met with the FDA was it last month, I think?
Yeah, I saw some of that, on social media.
So it's trying to get it'll get momentum. It'll get moving. And so, which is nice, because then, people can sort of let up, and at least most of the doctors who are taking care of a lot of women can let up and start being curious and start learning if that's what they want to provide for a woman. But the data is real. If a woman's going through menopause, she will increase her risk of dementia. She'll increase her risk of osteoporosis and heart disease. And then those are things in terms of mortality, like, but in terms of morbidity,
Right.
The genital urinary system, you're just sitting there thinking, if she has to wear a diaper for a while, and if she's in a nursing home, and she has a high risk of falls. If she falls, she breaks a hip. So like, if you start stacking that up, not having hormones is such a high risk in terms of cost to healthcare, quite honestly, because that's how healthcare looks at things. But really just quality of life, period.
Yeah, so it's not just about like controlling hot flashes or like mood like swings. It's like these big problems. And is that more for like a later in life? Or do those risks start like right away with the bone loss and things like
No,
that?
there is a little of a transition depending on a lot of factors, really. But to your point, when I first started being the outlier, even in conventional medicine with hormones, I was treating symptoms. I was treating vasomotor symptoms, which means you're treating later. A woman's already dropping hormones, getting erratic with her hormones. Just like you, Victoria, I tell them, get on an IUD, finish off your 40s with IUDs, because you'll have a little progesterone there, and that'll sort of take you to menopause. And then, I will put you on a patch, document the heck out of it, because I don't want to get sued for your breast cancer. And, because that's how I was trained. But yeah, I'm trying to be an outlier, and helping people not, kill their husbands. And, because it's crazy, because you could think of a woman who's very successful in her 50s in her career, like she's deep in her career in a leadership role. She goes to menopause, she can lose her and like lose her positioning
Yeah.
just because of her brain isn't right.
Yes.
And so, I
Yes.
started seeing that and, being a woman, I'm like, I don't know, that's sort of not cool. So I prescribed for symptoms, mostly because I didn't like to look at that mood as being, needing an SSRI, because I knew why
Right.
she was getting crazy.
Mhm.
I'm like, she needs estrogen. And I don't want to give her an SSRI because I didn't buy into that. So I did that for my part of my conventional training or my conventional years. And then when I transitioned to functional medicine, then it evolved further to be more of a prevention. So it was symptoms and then prevention. And then now I'd say I'm even stepping it up and leveling up even further where I'm saying, where I'm thinking, on the level of prevention, to your point, Hannah, is like, what's the timing of this? I start talking to my women at 40 and I'm like, let's start looking at your hormones. I just want to see where you are. Are you estrogen dominant? Are you sort of shallow with your progesterone? Because it gives me a sense of like helping her through. And really that first part of, and I think of perimenopause as two parts, and I think of menopause as two parts. And so the early parts of perimenopause, you're cleaning up cortisol, you're cleaning up like stress hormones, you're taking care of thyroid, you're optimizing those hormones first. Then as she's transitioning to the second phase of her perimenopause, then you start thinking, okay, when is it time for progesterone? And I layer in the progesterone. But even in that foundational base, I'm doing the base work, which is gut working? Do you have healthy microbiome? Is your liver detoxifying? How's your energy and your metabolism? Because in that mid perimenopause phase, the risks start, and it starts with like insulin resistance, weight gain. All of that's partly hormone driven, partly, some other factors. But then, by the time she gets into that first phase of menopause, which is very erratic, she still has a little bit of estrogen. And now I'm trying to push a lot of progesterone to, quiet down the drama. Progesterone quiets down the drama because estrogen's diva, and she sort of needs, to be calmed down often. And so you need the progesterone to do that. So that's why I lead with progesterone. She gets you ready, so that you're going to go through the crazy mess in that first half of menopause. And then by the time you're sliding in the second half, now estrogen's sliding out from under you. That's when you start thinking of pulling in estrogens. And so that risk in that menopause is when you start with the bone loss and muscle loss and, skin changes because of the estrogen loss.
Yeah. Victoria, you're okay.
There's a couple clarifying points. I mean, I have
Yeah.
a lot I could say personally. I'm 43, so I'm like early, but have very strong interoception. Like I've been able to feel my body very strongly my whole life. And I'm like, oh, I can really feel this. I think it's important to tell people who are listening the difference between health span and lifespan, because I've heard you use those terms. And I think we think in terms of lifespan. Somebody lived until they're 90 and it's like, wow, that's great. And it's like, well, it wasn't so great if they were like stuck in bed or in a nursing home or having to wear a diaper, so lifespan is chronological age and health span is biological age, which is like how robust and resilient are you during those years? Are you able to walk and be mobile and take care of yourself? And so when you're describing like that hormones long health span, I think it's a much bigger deal in real life. I mean, we can just say those words, but then like I have a friend who just graduated. Hannah and her and I all went through the same nutrition training. She's just got her NP and she's, doing her clinical work. And she's like seeing women as they get older. And if they haven't been supported correctly, it is heartbreaking because they aren't as mobile or completely immobile or have, like you're saying, the urinary tract issues and genital issues that are painful, and like that. So just so people get kind of a clear picture of that. And I think I also just want to point out to people, for you, Dr. Angie, like I said in the beginning, you don't just do hormone replacement therapy. One of the parts of you that is so impressive to me and I respect so much is she is really looking at the full person and uses I mean, an individualized, but
Mhm.
a system to look at like every aspect of someone's health. So you're using the hormones that you recommend in a very like well-rounded context.
Yeah.
And that seems rare to me. Like I don't see that a lot.
And it's unfortunate because that's hormones is the quintessential importance of personalization. You know, I think that
Sure.
functional medicine, conventional medicine, yeah, sometimes it's easy to sort of figure out some complex thing and treat it, whether it's prescriptive, nutritional, a supplement. And it's almost like this linear way of thinking, like, oh, I'm just going to do this, 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 this. And that might work for a few things, but quite honestly, hormones, no way. It's sophistication. When you think sophistication and complexity, um, it's not linear and, it's not. And when we talk about hormones, especially now with social media, it's out there. It's like everybody asks now. And people think, oh, hormone equals health and hormone equals beauty and hormone equals I'm not going to kill my husband. And the reality is no, it doesn't. You can give somebody hormones and they'll still do those. And actually, I have patients coming to me and say, I went to this clinic and I got my 3-pack. I got on estrogen, progesterone, testosterone all at once. And now I feel like crap. And I'm like, yeah, because it's sophistication, it's rhythm. You set the stage. You have to do all that work for the hormone to be what it needed to be. And estrogen isn't going to hop into this stage here and, be the beauty queen. She's going to hop in. And if your body's not ready, if you don't have a healthy gut and you don't have a healthy microbiome and your liver isn't cranking, and you didn't have enough progesterone to get ready for her, progesterone has to lead her. If you didn't do all of that and have that rhythm and have that system, she's going to come and be drama queen and it ain't going to feel good. I mean, that's exactly what women feel like when they're PMSing.
Yeah.
That's all hormone. It's a lot of hormone. It's unregulated. It's irregular. It's not balanced and she's a mess. So I think hormone doesn't equal, all those things that now are touted out there and people are like, I want my hormone. I'm like, no, you want, somebody to clean up, the
Right.
mess. Because all the time when people come to me, that's always a lot of times a woman will come to me, say, do you do hormones? I'm like, well, yeah, if you need them. Okay, I think I need hormones because I have all these things. And by the time we put her through and we work all the systems in a hierarchical way, like I say, I'm not even touching hormones till we deal with the base, till we get your thyroid taken care of, till you deal with your cortisol, till you make sure your liver's gonna do its job.
Right.
By the time I do that, then they don't need hormones, and we buy time. And I'm like,
So
I'll
that's
give you hormones when you're
yeah.
ready, when we need it. But by the time we do that, your hormones are fine.
So I'm glad you were talking about that because you do see on social media like
Mhm.
influencers really heavily like
Mhm.
balance your hormones, eat these things, use this, have this routine. And like I think it can seem kind of gimmicky, but there's also some truth in those things because a lot of
Mhm.
times they're talking about, working on your gut microbiome and supporting your liver. I mean, the things they're using to do that may be questionable, but like the
Mhm.
idea of that is correct, I think, in some
Yep.
ways. And do you think that, well, I have a couple questions. But one
Yep.
is like, do you think that now with our, kind of declining like health patterns because of the way we live in our modern lifestyle,
Mhm.
especially as women, and not being able to, recover adequately after childbirth, like with all of your, nutrients that you lose, and then
Mhm.
just being under stress all the time and not eating well and all the things
On birth
is
control.
a birth control, yeah, from a young age. And do you think all of those things are contributing to women having a much harder time when they're going through perimenopause and, into
Yeah.
menopause? And like,
Mhm.
just maybe it shouldn't be as difficult as it is.
Yeah.
Is that,
No, no,
yeah.
you're intuitively on spot. The woman who is going to do things natural. I mean, there's a woman who's just said,
Mhm.
hormones are not for me. And she might be fine. She'll get her hot flash and get through things. She probably will lose bone and all the things, but she's
Mhm.
fine with that, that life. Um, but the woman who does that transition without a lot of drama is the woman who has good base health.
Mhm.
She doesn't have a lot of toxicity. Her liver works well. Her gut's pretty clean. And I say gut and liver often when it comes to hormones, because so it's very important to realize that the drama queen estrogen, for example, she comes in at a certain time, does her thing, and then she's got to leave the stage for a while. And she leaves the stage by the liver. The liver has to, chauffeur her out with bile acids, drop her into the guts to get rid of her until we're ready for her again in another 2 weeks. And that bile acid, the microbiome, they coordinate taking her and sending her out and say, we're not ready for you for another 2 weeks. Leave the stage. And the problem is, if you don't have healthy bile acids, you can't chauffeur her out. She comes back in. If you have healthy microbiome, they don't chauffeur her out. She comes back in, and then she's there, too loud. Not enough progesterone to calm her down, and now it's drama. And so you need those in check. And so the people who just don't do that work go put in a pellet. Now they're like just rotating tons of hormone because it's not going out the way it should. And then on top of that, it's a pellet. It's not rhythm. So that's another important factor is like I think of hormone support for women in rhythm up until like she's to the point that she's done and like in her 50s. Then I will give her a hormone that's just straight and I'm not going to do rhythm on her anymore. But the woman who wants to start early with hormones, you need a rhythm with that, so that she stays healthy and doesn't feel like she's crazy, doesn't have some of the side effects that you have with hormones now. So yeah, those are really important to have in check, and having that rhythm is another sophisticated component of how hormones work, which it makes it really tough for anybody just to do because that's customized, that's personalized, and yeah, it
I
takes a
think that's
little
a
bit.
really important takeaway for people is that, you can't just like kind of like set it and forget it. There has to be some nuance.
Yeah. And I think with like, at least for me, my most like familiar understanding of hormones is like birth control pills or an IUD or something. And that is kind of a set and forget it. You're like, just take this one thing every day or put this in and don't worry about it anymore. And so it's not the same. It's like, it's different with BHRT.
The differences are route and dose. Like hormones for prevention of pregnancy is high dosed. When we're talking about bioidentical, it's trying to follow bioidentical levels, which is lower, much lower. And then the route, so oral contraceptives, go through the gut and then the liver. So that's causing more havoc because it's got to go through the liver. What keeps and that was what they did find out in Women's Health Initiative, is that the route matters. So when you're using bioidentical hormone, it should be transdermal for estrogens. And if you try to give oral estrogens, that was the risk of the clots and the heart disease and stuff. So when you go oral with the birth control pill, it's a whole different thing. It's a whole different dose, and they sort of screw up your microbiome. So it actually, sort of sets you up with a lot of junkie that you have to figure out when you now want to transition, to other hormones.
Yeah, and it's one of the most like deficiency causing drugs, right? Like it's like them and like anticonvulsants. I feel like I'm like reaching into the dark depths of my perimenopausal brain to remember this, but it can
Oral contraceptives, they deplete you of so many nutrients. Okay, I have another question, if that's okay.
Yeah, fire.
So with your background, Dr. Angie, with growing up using herbal and traditional medicines, are there herbs that are sufficient in helping? Because you see that too, like Vitex or different herbs for that claim to like balance estrogen and progesterone, and I also wonder if our grandmothers or great grandmothers were in tune with that and like using anything themselves, like figuring it out.
No, they were evolutionary. It was amazing. Like the midwives or the women in those tribes, they were very knowledgeable about those things, because the number one mortality for women was pregnancy. So it was amazing that they what they learned without sophistication. But, I actually use botanical kind of supports around liver health and microbiome health and gut health.
Yeah.
Do I think that there's an herb that's going to replace a hormone? No,
Yeah.
it's too sophisticated. So what we're doing when we're just pacing you, we're just saying just what I said. If you can keep liver healthy, you can keep gut healthy, that'll hang on to a cleaner hormone until you're ready for them, until you need them. So definitely I'm using tons of botanicals for liver health. I mean, it's like that just goes hand in hand with liver. I actually do better controlling cholesterol with certain botanicals than I do with prescriptive.
Oh.
And then the gut microbiome as well is very in tune with Mother Nature. I mean, that's just, information that has been shared and, so the microbiome sort of knows what to do with those kind of things.
Yeah.
Modern life doesn't have that. Modern life
Yeah.
doesn't have fiber. Modern life doesn't have polyphenols. All of those are the communicators.
Yeah.
And then they don't have all the other specific things and the nuanced botanicals that we use. So it is good, if you have somebody who's trained in supporting that, the Vitex and all, that's really what that's for. But you do all of that to buy you time. You do all that to set the stage. And then, when you're like, okay, hot flashes are still there. And then you start looking at data and seeing, and I'll look at data in my gals when they're starting to, ask of things. And actually, I'm asking them, because I do a lot of data. I'm like, should we look at your hormones? Like, yes. So I'll look at hormones at least if if I could, I would look at it twice a year and just see what patterns look. Because as to your point, Victoria, it's all over the place. But then it's sort of, you could see not with hormones, but with FSH, LH, some of these other markers, you can sort of gauge, is she's still pretty good in that early stage. Oh, she looks like she's climbing now. When I see that, that's when I start introducing progesterones. But that's already sitting on the botanicals. What's that?
I was going to say I'm coming right out to Colorado after this.
I know. I'm like saving all of your contact information.
Go get in the car and just start driving. I mean, I think that Hannah and I both feel that way. Maybe it's because I think it's like I said, it's rare that you speak to someone who is approaching it with such a nuanced, contextualized approach, thinking about the evolutionary piece of it, also wanting to like support how women feel. It's like, it's wild to me that it's revolutionary that somebody is finally giving a shit about how women feel. It's like women have been caring, but it's in science as a whole. I know that it's not just that, like there are issues with like studying women because of our cycles. It's more difficult to control and like that. But by and large, it's like, yeah, we have lives, like we're out here doing stuff. And to your point, look, I can see right now, like in our work, when Hannah and I are working, I miss details that I did not used to miss, would have never overlooked certain details. And then I see it later and I'm like embarrassed, I'm like, oh my God, I can't believe I missed that. And I have a dear friend and she's like, you're starting to get like low progesterone brain, like go see somebody. So I think, just having conversations with you and hearing this now for me is timely and I feel lucky versus 10 years from now when it might be worse.
Yeah.
Is there a point where it's like too late?
No.
If a woman doesn't address anything until she's like 60 or 70 and you can still help?
It's never too late. The body is unbelievably, well, that's evolution. The body says, oh, thank you very much. You're giving me something I can work with now.
Yeah.
Maybe, but I'm going to work with it. But the body will respond and tune really well. It's harder as you get older, no doubt. Do it younger. But timing in terms of treatment, the supported time frame is within 10 years of menopause. And before 60. That's what's defined as like the sweet spot of hormones. And then it was like, oh, we don't know what to do after 60. And some women would just continue with it. Some women were pulled off of it because of fear of side effects. Now they're saying, no, keep with it. I will go to my grave with all my hormones for sure. And the other question then comes up is like, what if the women that we've denied, the 68-year-old woman out there we denied, and she says, oh, look, all this new stuff. Can I come back and get back on them? I think that that's sort of the gray spot right now. people are still conservative about that. I don't. I will put women on hormones after I do all the work, after they do their
Right.
work. And the biggest thing for that is just making sure, and it's because I feel comfortable with the data right now. I feel comfortable with my mentors and their experiences. Like if you add up all the mentors out there, they've got like hundreds. I mean, the women that are training us were like the hippie doctors that said, "Screw you, I'm going to give my gal hormones," and she stayed with it on the edge. And so she's got all this knowledge, and so she's, there's a lot of them are sort of passing that knowledge down, and then it's overlapping with the scientific sense around things. And with our technology now, we follow, like, for example, I feel comfortable doing that because I'm following Dutch tests. I will look, and some people don't think that that's adequate because there's no evidence for it. But I'm like, well, there's no evidence because nobody studies women, number one. And, but at least I have some information that I'm going to sort of sit on. And in that Dutch test, I can follow her estrogens and see, is her estrogen becoming a diva? Is she getting drama? Because you can document that on a metabolite. Or is it she's clean? She's doing her thing. And you can differentiate that on a Dutch test. And now we're getting more sophisticated for that 68-year-old woman. Now we're getting more sophisticated to say, what level should the estrogen be to protect your bone?
Yeah.
And that's coming out. And there's data we're following, and there's a number I look at when I'm looking at that Dutch, and I put that 68-year-old on there. I'm like, we're good. You're falling right where I want you. And so it's not like set it and forget it kind of thing. It's like, no, I'm going to monitor and see where you are. And I'm going to look at your muscle mass, and I'm going to look at your VO2, and I'm going to look at your calcium scores, and I'm going to harass you about imaging your breast. If you don't want to do mammogram, you go do your ultrasound.
I love you.
And then if not, you go do an MRI. I just need you to image your breasts.
Yeah.
Why? Because you're going to die of a heart attack or a cancer. And as your health advocate, I just need to be honest that I'm going to, tell you what you need to do. That's like a coach and, tells the athlete, I know you don't like to hear this, but this is how you extend your health span. Why? Cause that's what you're coming to me for. That's what you want to do, is invest in your health. And these are the real conversations that you need to hear. Most of my patients, when I start looking at through that lens, I don't have high risk patients, but I don't have the typical American patient either, but, who probably could be high risk. Like my colleagues who are looking at that, that typical, if you look at the typical industrialized patient, they are high risk, they already have plaque. They already have insulin resistance. They have all those. And you're going to go throw, because I just said, you can't go throw hormone in that. It'll be a mess. It'll be something.
Yeah.
So they have more issues. So, when you see it that way, then it's like, no, this is, I will pull in a hormone, to optimize somebody's life in terms of, their experience, the wisdom that they need to pass on, because we sure the heck need that. And I will support that, and feel comfortable doing that.
Yeah.
I mean, I kind of wonder, like, when you say, like estrogen is a diva and progesterone is kind of her handler, if people like have really, I wonder, one, if you're talking about that at like a biochemical level.
Yeah.
Because there's an also like, I mean, Dr. Angie, like I totally had the experience in my late 30s where my husband left to go on a snowboarding trip and I was 100% convinced that he was going to die. I mean, it was a pretty like a heli trip, a little risky, but I just had like years before I had bought through Quest like a hormone panel, and I was like, oh, I still have this. I'm just going to go get them run. For some reason during that time, and my estrogen was like off the charts, no progesterone at all. And so, yeah, at a biochemical level, estrogen is acting diva-ish, but in your day-to-day life as a female, if you have those moments where you're like crying, I was like, I'm not a crier. I would weep.
What's wrong with me?
Yeah, I was like, I am losing my shit. And it turned out like to the point where they actually ran FSH and LH. Like they were like, maybe you have like some type of pituitary tumor.
Yeah.
They imaged my ovaries. Maybe you have nothing. I think I just have liver
Detox issues.
my own theories about it. But to your point, it's like it brings that out in us in our day to day while it's being diva-ish also, with how it interacts with our cells. But that might be what women experience. If you're kind of like, what does she mean? estrogen is a diva. You
Right.
have felt that feeling. If you felt it, maybe is the best way to say it.
Yeah. I mean, searching like a Google search for do I have estrogen dominance is probably a pretty high, ranks pretty high.
Huge.
Women are searching for that. And I think for listeners like who are listening to this episode, you're probably aware, interested or learning about BHRT. But I think pointing out that sex hormones do so much more than help you have a baby or regulate your cycle. Like they affect your entire body. And so that's why when they start declining because you can no longer healthily carry a child, it affects all of these areas like your bone health, your brain health, your gut motility, all this stuff that I don't know. I never really associated with sex hormones. I thought they were just all about like, regulating your cycle and that's it, like,
Yeah.
yeah.
I was gonna sort of clarify your question about that, Victoria, with the diva comment, or the way I think of her, of estrogen. Diva, I think of it as can be, there's two sides to that. She can be a
I was an opera
hot,
singer. I'm with you.
she could be a hot, intense, like just powerful. That's estrogen. That's a diva. But she can also be drama and sort of lose things. Like it's just like, she has intensity, and it can be a powerful, good thing, or it can be drama. And progesterone really guides that for her. It's almost like a superstars, you see them and they can be in a good space and they're doing wonderful things. And then you hear their drama on, Entertainment Tonight or whatever, thing of, oh, did you know, they've got, this going on. And progesterone's like the manager there, like, hey, don't do those stuff. You've got to, hold a certain position here. So I think of estrogen as being very much a powerhouse, but can be very, very violent and dramatic when she's not, when she doesn't have her progesterone with her.
Yeah.
Balancing her out.
In that vein, Hannah, do you have more questions? I'm like, we could keep you here for a really long time, so you're going to have to be like, hey, ladies.
I'm good.
So would you speak a little bit, if you're comfortable with it, to the different types of progesterone or estrogen that women might be recommended? Like I know there are like bioidentical forms and then there's synthetic forms, and like what should women be aware of?
So as I mentioned, so we'll start with progesterone. So there's the synthetic progesterone, the medroxyprogesterone acetate. Those are the ones that are in IUDs and birth control pills. So there's that synthetic component, and then there's bioidentical progesterone. The synthetic medroxyprogesterone is IUDs, could be pills too, capsules, or in terms of just individual progesterone or combined with estrogen. The bioidentical part of progesterone is either creams, or capsules or pellets. So I guess in the conventional world, there's also a depot. They'll put progesterone in. I forget those kinds of things since I've been out for so long. I usually don't use it. I'm like, if you're going to use progesterone, well, if you're going to use any hormone, I would highly recommend bioidentical. But you can get just regular progesterone capsules, and they're not that bad from conventional medicine as pure progesterone. The only thing with pure progesterone capsules, like a 200 milligram capsule or 100 milligram capsules, their carrier oil, it just might not be the greatest oil.
Funky.
So then you go to compounding, who will give you an MCT oil or coconut oil with your progesterone. So you can still get some decent bioidentical-like hormones through conventional medicine if they order progesterone capsules and then they put a patch, because the patches are bioidentical conventionally. The other estrogens conventionally are just the birth control pills or the patches. So, and the oral, there's a separate single individual oral, and they were using those often. Actually, I had a patient come to me and was still on it. I'm like, what are you doing on an oral estrogen? She's like, oh, they told me it's for my hormones. I'm like, oh, no, let's get the heck off that. Somebody didn't pay attention to the Women's Health Initiative. That was the one positive thing we heard. So it's still there. I don't know who should be using that anyway, from just a maintenance support of replacement. So that's conventional. I use all bioidentical creams. If for you, for example, for Victoria, younger women who are just sort of doing this thing, I'll do just a general light cream, 40, 50 milligram cream, just 2 weeks out of the month. And just sort of cover a little. Sometimes if that estrogen's way too high though, then she needs a progesterone capsule. And then in a compounding pharmacy, you can adjust that dose. So that's compounded progesterone. The other options, what else are there? The pellets. So then there's the pellets that people use. And as I mentioned, I think pellets work really well for women who are pretty deep into menopause. Like she doesn't have any inkling of the hormone fluctuating on her, flatlined all the way. You could
Mm-hmm.
pop some pellets in her. It won't phase her as long as her liver's good, her gut is good, like all that
Right.
stuff is good. She'll probably do fine with a pellet. It's the women in between, like the 50s, 40s, 50s, that she's got way too much flux that I like to use creams because then I can adjust. So I'll start off with estrogen creams so that I can adjust up and down if I needed to until she really just, flattens out, and then we can throw a patch. Unless she's like, I'm tired of creams, can we put a patch? But I often find with a patch, I can overshoot easily sometimes because her hormone hasn't quite gotten there. So that's the difference. I think birth control pills are higher dosed. Bioidenticals, no, it's very low. Um, but my conventional colleagues have an opportunity to provide some decent hormones if when they get the knowledge and the skills.
Yeah, I think and tell me if I'm wrong, but I've talked to people who are like, I tried hormones and it's just like hormones and it was terrible. I felt worse. And then they
Yeah.
go off it completely. And it's like, well, what exactly,
Yeah.
there's so many factors, like you're saying, like liver, gut,
Mhm.
thyroid,
Mhm.
all of these different processes that you have to pay attention to first. And then what type of hormone, what was the dose, what was the
Yes.
timing, like all of these different
That's why it's so
factors matter.
nuanced. Mhm. That's
Yeah,
why nobody wants to do it, actually. They're just like, let me just give you the
yeah,
pack. Let me give you the 3-pack and see how
send
you
you
do.
home.
Yeah.
And how long,
Yeah.
like, typically do you work with your patients on all those foundational things before starting them on a hormone routine? Like, does it take a year or is it?
Depends on where they are. So like if in the
Yeah.
early perimenopause versus early menopause versus later menopause, like there's
Mhm.
urgency when you're later menopause. Versus early. Early, you're just sort of setting the stage. Later menopause are like, get me on hormones now.
Yeah.
And in that situation, that urgent situation, yeah, you can sort of do a quick gut liver reset over a course of like a month or two. And then and at that time, I'm starting to look at their hormones. And then I'll bring in progesterone first because she's not going to be crazy right off the bat. But she gets, that woman gets some coverage so that by the time I'm bringing in estrogens, she's already 3-4 months into a good program. But she's already feeling better because most of the time she's coming in with hot flashes and she can't sleep, and progesterone covers a lot of that. And then I'm giving her vaginal support too, because that's the other big thing. So I have no problem if a 45-year-old woman came to me and said, I'm feeling a little dry, to give her some vaginal estrogen.
Mm-hmm. Yeah.
So I'm trying to buy her time and treat, the thing that bothers her the most. And it's usually sleep and vaginal issues. And typically if you can get progesterone, the emotional issues sort of calm down too.
I'm gonna like just dip myself in like a vat of progesterone. Come out like a new person. um, I have one last question and I feel satisfied. Are there any patients that you've seen where you're like, hormones are just not for this person? Like, I know that's such an individualized question, but are there any
Yeah.
populations of women, like if they do have a really strong family history of breast cancer, endometrial cancer, like
Not
it
unless
doesn't?
they themselves had cancer, and I wouldn't even say no then. I just send them to a colleague who gives them hormones with their breast cancer history.
Mm-hmm.
That data doesn't jive either. It's not. If somebody told me my mom had cancer, my sister had cancer, I'm more cautious. If the woman said there's all this hormone cancer in my history, I don't want any hormones. I just educate them. I'm like, no, that's actually not what the case is. And those women, yep, the genetics probably isn't estrogen. The genetics is probably a COMP-T genetics or methylation genetics. And all those women just didn't methylate their estrogens, and their estrogens became drama. And
Right.
so we said it's the estrogen, it's just the genetics of the liver that's passed along. And so you can test for that. And that's sort of part of the Dutch. You can do a genetics test and see that and say that's the genetics. Because the other side is a woman who comes to me and says, I don't have any any risk factors, I did the genes, and what they're talking about is the BRCA1 genes. I'm like, oh, that's not the majority of cancers, and so just educating people on the reality is that from the genetic standpoint, it's not estrogen genetics. It's likely liver genetics in terms
To
of
set the
method.
stage,
Yeah,
genetics.
Yeah.
yeah. And so I can educate a woman one way or another just for education, so she can make a different decision knowing that she has different information. She may still say no to hormones. The person that I say no to, as a person who's not willing to do the work in terms of the liver and the gut, I'm like, I ain't going to drop a hormone in that. You can find another clinic because there's plenty out there. You give them enough money, they'll give you a hormone. And or the woman who has significant risks. And my risks that I say no to are more of the cardiovascular risk. If they, taking time bomb in terms of a cardiovascular event, I'm not going to drop an estrogen in that. And I'll just try and continue to encourage them to take care of the thing that is going to affect their health span and longevity.
Yeah.
Because I think hormones are like, number one part of it that's accessory. It feels good. You look good. Your sex health stays intact. All of that's like accessory in a way. Then you add the other layer of prevention in terms of the other things. But in the end, you have to deal with your insulin resistance. You have to deal with, the cardiovascular risks first and foremost, because those are the things that are going to turn on bad stuff.
Yeah.
Whether you have hormones or not.
Right.
Yeah.
Right. That's, yeah. Yeah. It's such a important way that you work. So, and just again, to clarify for people, your process is so data driven that, yeah, when you laid it out for me, I was just like blown away. Like nobody does that, but you do. You absolutely do that with every person that walks in your door. And to me, it just knowing what little, we know about, like you're saying, like liver physiology, gut physiology, thyroid physiology, adrenal physiology, like all of these like mechanisms to get all of that straight before you introduce this, what could be, an even more harmful compound. But it's like when done in the right way, it is extremely beneficial. It's like, to me, critical thinking medicine. That's what you are.
Yeah.
You're a critical thinking doctor.
Yeah. Well, that's sort of like when I introduce patients to the work that we're doing here, I use the analogy. I think I've told you this, Victoria. It's like health and youth is sophisticated organization and communication. So thinking about it in a very simplistic way, if I'm just going to throw stuff in this, it just doesn't hit anywhere. It doesn't gain momentum, which is why conventional medicine does nothing for most people. Conventional medicine just contains chaos and maintains disease. But if we truly are in a space of like, I want back to that sophistication, I want back that organization, you got to be sophisticated in how you're doing it. And sophistication isn't simple usually.
Yeah. It's, to me, we've talked about, we're going to do episodes on functional medicine and on conventional medicine, just looking at like how we do like the history, what our biases are, what the research shows. And when I talk to you, it comes up for me over and over where I'm like, you are doing real functional medicine. Like you are doing functional medicine in the way that I like, the spirit of it truly was meant to be, versus like, it's like, I feel like a lot of functional practitioners just kind of replace like drugs with supplements and herbs, and they
Like, we're going to put
replace.
you on a protocol.
Yeah,
This is a protocol for that. This is a protocol for this. Here you go.
Totally. It just gets like one gets replaced with the other. And it's like, I was having a conversation with a colleague the other day, and she was like, we're seeing people come into the office and they're on their like eighth or ninth functional provider, and they've spent $50K out of pocket, and they're still like, maybe they're a little better, like, okay. But like, they're still experiencing symptoms. And I'm like, yeah, that was me. I totally know that experience. And that's it's unfortunate, but I'm like, I'm almost like, Dr. Angie, you have to like create a school.
Well, in my mentoring group, AJ Virgin, that's what she told me I needed to do next.
Oh, perfect. Yes.
And I'm doing that. I'm trying to put it together because I am the unicorn, and I have data that things are working. we need to do this more. And I think the point is you have to make it such that because it's complex, you have to try and simplify it as much as you can so that it can be a system that can be repeated. Yeah, it's sort of trying to see the nuance, and AI is going to make it much easier. I'm trying to think about that
Yes. Oh my God. I want to
yeah,
like
I'm putting
create a custom chat of you.
yeah, I am creating my custom chat.
Awesome. Okay. Good. Good.
I am creating my custom chat, which is quite it's amazing. It's like wow, the amazing things to do. But if you do that, then you can sort of set your resources there, and then set a system, and then you don't have to have somebody think as much as I think, because I think, that's was my thought is I think a lot. So if I was to train somebody, would they want to do this much thinking, and do the work that we do here? But if you had like that chat and that coworker, in a system, then not that you want to be lazy, but at least, you can have a backup of something checking up on you in terms of,
Right.
the sophistication that I just described with the body.
Yeah. And you like it. It's
I
like
love it.
you totally love it. So it's
Yeah.
like a good fit for you.
Mhm.
Hannah, do you have any other
I don't think
questions?
so. I think that was just fabulous. I love everything we covered. Thank you so much for sharing your knowledge.
Yeah, we're gonna go on a road trip. No, I'm serious. I've said to Andrew, I'm like, if I have really been considering going on hormones, I'm like, we're gonna take a trip to Colorado. He's like, great. He's a snowboarder. That's actually like a lot of the packing back there is
Yeah.
his snowboard gear.
Yeah,
So
yeah.
he's like, you want to go to Colorado? Awesome.
Come on
Um,
by.
okay. Anything else, Dr. Angie, that you want to leave with?
No. I think that we're in a great time in
Yeah.
medicine. We're in a great time. But the problem is that there's so much information, and it doesn't mean that information is knowledge or wisdom. And so
Right.
that's the challenge of what's exploding right now. And having folks at least taken back and trying to get a sense of where that information is coming from. And I tell my patients, I don't take advice from somebody who's not seeing patients.
Yeah.
I mean,
Yeah.
you got to be a provider seeing patients to understand this nuance,
Yes.
at least with hormones.
Yeah.
Yes,
And there's
definitely.
plenty of influencers out there that are pushing the needle, who are trained, providers who are prescribing and have this view. As a matter of fact, that's why I have this view. They're my company.
That's
Yeah.
cool. Yeah. I mean, we come to this point in
Mhm.
almost every episode where it's like there is so much good. And the
Mhm.
problem is, how does somebody who is not educated in this field disseminate? It's like,
Right.
what is that the right word? Disseminate? How do
Disseminate
they?
information. Yeah.
Like,
No,
how do
that's
they incorporate
Uh,
all this
yeah.
in
Like,
the
how
yeah.
do they?
process?
That's totally. I really do need to come see you for projection. How do they like differentiate
Yes,
between?
Differentiate.
different.
Yeah.
Yes.
Yeah, I mean, it's hard, I think, for Hannah and I, and we're not doctors at
Hmm.
all, but like we have been studying this
Yeah.
for decades. So, yeah, for somebody just scrolling on their phone,
Hmm.
maybe Dr. Angie, if you are comfortable, I mean, we're definitely going to link to your website and tell people about your practice. But if there are people that you're like, hey, these are good people to follow that have, like
Yeah.
social media accounts that are really active, we can put that in the show notes with the research
Yeah.
links and like that.
I think I'll send you two. I'm starting to post. I'm not the greatest post because I'm in the arena.
Yeah. You don't have time for that.
And I'm not,
Dedication.
I'm not chasing the head
Right.
of the social, but I post because I want to post for patients, my patients.
Yeah.
So that's sort of my purpose. Is if I throw something out there, it's because I need to keep my patients up, because they don't see me but once every 3 to 6 months when they're healthy. So just to keep them in loops. So that's sort of what I've set up. So I'll send you, what do they call it, a handle or whatever that,
Yeah.
Yeah.
The
Whatever
handle.
however you get in. I'll
the
have to
handle.
ask my
Yeah.
staff,
Yeah.
but
You did it.
there you go.
Thank you so much for
Yeah.
coming on. It was a
No,
pleasure.
thanks, gals.
And
It's fun. It's fun. I love this
yeah,
style. I love
so
this
good.
style.
And we have some friends in Colorado. Like actually a woman that is going to speak at the membership today lives in Colorado. I'm like, I want to put your name out there as much as
Yeah.
possible and just as a model
Yeah.
for people. So
Yeah.
yeah, thank
Yeah.
you.
Thank you, Dr. Angie.
Thanks, Hannah and Victoria. Good to see you, Victoria. Have a good day.